Welcome back everyone. Let us see the case of the month. The case was contributed by Dr. Ankit Balani. So let us see what is the case. An elderly male patient who presented with left-sided partial seizures with secondary generalization, and on admission the blood glucose levels was 500 milligram per deciliter and HbA1c was 14%. You can see the axial T2, T1 varied images, the flare images as well as post-contrast T1 varied images. Try to locate the abnormality initially. Look at the symmetry gives always a diagnosis and always gives you to localize where the abnormality is. So let us see what are the findings. You can see the swollen gyri on T2 as well as on the flare images. You can see compared to normal gyrus, you can see it is thickened and increased in signal. You can see on coronal as well. And an important finding is the subcortical white matter T2 hypointensity, which is crucial in this case for concluding the diagnosis. And on T1 again it is, you can see appreciation of the gyral edema, and on post contrast there is no significant enhancement. So with all these features in a elderly patient who is presented with partial seizures with increased blood glucose levels and HbA1c of 14%, the diagnosis is non-ketotic hyperglycemic seizure, and it is the one of the manifestations of non-ketotic hyperglycemia. Previously we have seen one case of non-ketotic hyperglycemia presenting with unilateral basal ganglia and caudate nucleus hyperdensity on CT as well as altered signal intensities on MRI. So this is another manifestation. Another manifestation can be non-ketotic hyperosmolar coma, and the characteristic feature in this non-ketotic hyperglycemic seizure is the subcortical T2 or flare hypointense signal, which is typical with posterior predilection, either posterior parietal and occipital lobe involvement, with overlying cortical hyperintensity with swollen gyrus. And sometimes the cortical or retromeningeal contrast enhancement may be seen, very rarely. And the pathophysiology to explain the T2 hypointensity is still debatable. And the most commonly explained theory is the iron deposition or possible microhemorrhages or press-like. So various pathophysiologies have been explained, but most common etiology is probably due to iron deposition from free radical release. And treatment includes the control of seizures of hyperglycemia. So this is the case of non-ketotic hyperglycemic seizure. Thank you all.